my 2 cents on how to manage patients who are preparing for surgery. And I know this is not going to be sufficient 45 minutes to pack everything in it. And perhaps I should entitle this as a crash course on management for pituitary surgery in over 45 minutes. But I'll try to emphasize some salient points that I think are important, especially for those patients that are going to undergo surgery that you guys will be managing on the floor over the next few days post-operatively as well. So this is a talk that I actually prepared for my Endocrine Society Meet the Professor session. So there could be some questions in there, board questions that I thought maybe we'll test you guys along the way. So my outline is to talk about the introduction, take a little bit of talk about the pre-op, peri-op, and post-op management, dividing it into both early and long-term, and then perhaps a couple of cases to illustrate some points and some concluding remarks, okay? So we know that pituitary lesions are actually more common than originally thought, that pituitary adenomas and craniopharyngeal duct tumors are actually perhaps the second most common brain tumors in the US. And pituitary adenomas are probably more common in adults, and craniopharyngiomas more so in adults, in kids and adolescents. And they typically present for consideration of surgery if they have potentially mass lesions, which can be potentially, they present with headaches, visual issues, or ophthalmoplegia. Alternatively, they can also present with hormonal dysfunction as well, which typically leads them to see us originally before they are sent to you guys. And important to know that not all pituitary tumors require surgery, especially prolactinomas, because they typically do respond very well on medical therapy, and medical therapy is advocated as the first line and not surgery. But otherwise, all the other tumors that that potentially require surgery based on the fact that if they are having potential mass lesions or hormonal hyperfunction aside from prolactinomas would require surgery, be it transsphenoidally or craniotomy. Obviously, we need a multidisciplinary team approach. We need to work them up before surgery. And obviously, we need to manage them during and also short-term management after surgery. And then what happens after they are seen and they've had surgery long-term in terms of hormonal replacement. So for the pre-op evaluation, eye exam, visual field exam is important, especially if the MRI shows any degree of compression to the optic chiasm. We also have to evaluate for other comorbid conditions, typically like patients with Cushing's or acromegaly do have cardiovascular issues that may be important from an anesthetics point of view. We need to assess the functionality of the pituitary tumor, again, because sometimes there's some cases where we may need to pre-treat them ahead of time before considering surgery. These are the typical labs that we tend to do over in the ambulatory infusion unit. We typically like to measure or perform the co-syntropin stimulation test before surgery just to get an idea of their hypothalamic pituitary action. Most crucially, we need to make sure we identify that they have or not, whether they have or not adrenal insufficiency or diabetes insipidus, because these two indications need to be treated beforehand. Potentially also, if they are hypothyroid, that needs to be treated after treating the adrenal insufficiency, not before. Don't worry about the sex steroid like testosterone or estrogen, because that we can manage that after surgery. And certainly, growth hormone is not something that we consider treating at least before surgery. And again, for anesthetic issues, we want to make sure that the comorbid conditions are addressed before surgery. Okay, so for patients with adrenal insufficiency, hydrocortisone is preferably used as opposed to prednisone. because it typically mimics it helps mimic the physiological circadian rhythm more effectively than prednisone. This is kind of debatable as to whether we routinely treat patients with steroids for surgery or not. Some places you will find, presumably in the places that you worked previously, steroids are given routinely for surgeries. We don't typically use them, and I'll give you some data as to explaining to you why we don't prefer using steroids preemptively if the HPA axis is intact. Obviously, with thyroid replacement, if they are hypothyroid, and if they have diabetes insipidus, we'll treat them with desmopressin as well. Again, one needs to identify this ahead of time, important before treatment, because that will help guide you with treatment during and after surgery in terms of their fluid balance. So here in Swedish, we tend to keep these patients for ranging, if everything goes according to plan, 1 to 3 nights. Generally 1 night to 2 nights. We measure their post-op day 1 cortisols, and sometimes if they're still hanging around in the hospital, we tend to measure that on the second day as well. But generally, the first day is important to measure their cortisol. That will give us an idea as to whether or not we need to give them steroids before we send them home. Now, the data actually is pretty clear, suggesting that if the AM cortisol is below 5, AM meaning between 8 to 10 AM, then hydrocortisone should be administered before they go home, doses ranging between 15 to 25 milligrams a day. If they have a cortisol in the morning of above 15 micrograms per deciliter, you can let them go home without any steroids. Typically, fluid balance issues tends to occur within the first 24 hours, 48 hours. So fluid balance ins and outs needs to be monitored as well. And obviously, it's important to catch them early if they have early DI. And then also other things which I'm sure you guys would be looking out for, like hematomas, ophthalmoplegias, or CSF leaks. And the time frame of these things to occur, such as infections, sinusitis, and even nosebleeds, can tend to occur within the first 1 to 3 weeks. So when we see these patients during the post-op day 1 or day 2, we tend to, or actually we give them a folder with all the potential complications for them to look out for. And so we kind of spend some time counseling them and their family members as to what to look out for, and to give us a call. We have our card in here to give us a call if they experience any of these symptoms immediately or within the first few weeks after surgery. And that's pretty much, you guys will know, will request for CTs and MRIs if the vision is worsening or if the CSF leak is pending. So just a slide to show you why some patients develop sodium and fluid imbalance. So typically we have what we call a triphasic response and an isolated second phase response. So a triphasic response occurs when there's a complete transection of the infundibulum. And as you can see, the AVP neuronal bodies are located up here in the periventricular nucleus and the supraoptic nucleus that transcends downwards in the posterior pituitary to the axonal terminal and releases AVP. So when you transect that part over there, immediately, or at least within the first 24, 48 hours, patients have AVP deficiency, i.e. DI. And that's usually the time frame when one actually sees DI occurring. But over time, there's also AVP that's actually that's situated in the posterior pituitary. Over time, when the degeneration of the axonal terminals occurs, the AVP is then released passively into the blood circulation, and that's why you can have a patient from DI actually bumping up to have SIADH. And that's crucial because that needs to be identified because the treatment obviously is different. And then once the axonal terminals starts to fully degenerate, then the patient can go back to having a DI. So they have what we call a triple phase response, which is why the treatment is actually very different. But most often we'll see that surgery, if you have a transaction, a partial transaction, where there's still some neurons that are still unaffected, transcending through the posterior pituitary, then you'll find that only partially the axonal terminals are affected. So these degenerating axonal terminals will then release AVP, but then the amount of release is obviously not as great as all the of the triphasic response phenomenon. So you can have a milder SIADH, and sometimes patients actually can compensate if their thirst mechanism is actually still intact. So these patients don't end up having DI because they still can have a partially functioning hypothalamic hypophyseal tract that is still supplying AVP into the circulation. So in this situation, they can have a little bit of bump of a SIADH, and then they can go back to normality. So DI, important to look out for would be polyuria, polydipsia, and they may or may not have an intact thirst mechanism, especially if they're drowsy or they're not, if they are cognitively impaired. Importantly, the first 24, 48 hours, and other factors that can contribute to polyuria would be excessive or overzealous IV fluid administration. So make sure that that's not the case that is contributing to the patient's polyuria. Sometimes their blood sugars can spike, especially if they're put on Decadron, which is a potent glucose aggravating drug. So hyperglycemia is also another important thing. Patients with acromegaly who have high levels of growth hormone, and when they are successfully treated, growth hormone levels drop. Growth hormone also has fluid retaining properties, and when growth hormone levels drop, they can also develop a certain degree of polyuria as well. So those are the three things that perhaps you kind of want to keep it in the back of your mind when you're seeing a patient who has polyuria, because they may have polyuria for other reasons and may not be related to the fact that they're developing DI. So these are the laboratory data that we tend to measure to confirm the diagnosis before treating them. We obviously monitor the fluid intake and output. We prefer to treat them with DDAVP on an as-needed basis and not giving them scheduled dosing, because, like I said, sometimes patients can actually revert to having an SIDH, and that can potentially crash the patient's sodium. So make sure that if you do treat them initially, at least, you treat them as needed based on their fluid or their urine output as well. And we like to potentially preferably use oral DDAVP if they are able to swallow the tablets. If not, IV DDAVP can still be used as well. We allow the patient to drink to thirst, and if the patient's thirst mechanism is impaired or the patient is drowsy, we can supplement that after the diagnosis is made of DI with fluid replacement. DDAVP delivery means can be in the form of injections, spray, and tablets, and you'll see that some places where, and I've given this lecture to some to other institutions, and I'm surprised that some places they use the spray, but we don't like to use the spray, partly because the nose is congested after surgery, and that's difficult for patients, at least in terms of the absorption. But you can see that the injections have a greatest bioavailability, or the IV injections, as opposed to the tablets, which is why you see that the dosing is a lot different between the tablets and injections. So the point I'm trying to make is that tablets and injections do not have the same dose, and they're not dose for dose if you're converting them. In terms of monitoring for resolution, clearly, again, fluid balance is crucial. and close monitoring of the serum sodium levels is important. If there's potentially any hint that the patient has adrenal insufficiency, low cortisol levels can also contribute to hyponatremia as well. So sometimes if the patient's sodium is dropping, it may not be SIADH. It could be the fact that they're developing cortisol deficiency. So if in doubt, you could potentially stress dose them with hydrocortisone. But make sure that afterwards, the anterior pituitary function should be reevaluated. So for SIADH, typically monitoring the plasma osmolality, which is low, and the urine osmolality is typically above 100. But these patients are generally euvolemic as opposed to hypovolemic. And because of the fact that they are conserving free water, you'll find that the urine sodium levels tend to be a little higher, certainly compared to if they have CSW. Okay. Again, hyponatremia, make sure hypothyroidism, AI, or even diuretic use is excluded because that can actually mask the picture as well. So we don't see much as CSW in pituitary patients, and I'm told that it tends to occur more so in patients with subarachnoids. And a crucial difference would be the fact that of their hydrational status. So because for SIADH, the main mechanism is the retention of free water. And so they are kind of losing a bit more salt in their urine. Whereas at CSW, they're basically losing both free water and salt, which is why the osmolality and hematocrit, all these surrogate markers for dehydration, is affected as opposed to SIADH. So treatment for SIADH, again, is really dependent on how rapid the sodium levels fall, because if you have evidence that they've dropped within the first 24 hours, you can actually rapidly reverse them. So don't be afraid to do that. Although most of the time we don't know how long they have been hyponatremic for, because if they're more than 24, 48 hours, then you might want to normalize their sodium a little bit more cautiously. So fluid restriction is one way of doing it. Salt tablet is another option, although it can be a little distasteful for patients. Patients sometimes find it hard to tolerate salt tablets. Sometimes we've had to resort to using hypertonic saline as well. We also, I've used a few times AVP receptor agonists. These are very expensive medications. So if you do prescribe that, it has to be started in-house as opposed to being an outpatient, because we need to monitor the patient's fluid balance. So patients, if you are starting them on tolvaptan, which is the oral version, and conivaptan is IV version. So for tolvaptan, if you're starting that, you have to tell the patients, or you tell the floor staff, that they should not be fluid restricted. So you need to lift the fluid restriction if you're putting them on tolvaptan, okay? And so how does AVP work? So vasopressin attaches itself to the basolateral membrane of the receptors. It stimulates cyclic AMP to increase the production and the shuttling of aquaporin to water channels. So these aquaporins actually attaches itself to the apical membrane, opening up its pores and allowing the movement of water downwards into the osmotic gradient. So when this goes this way, free water excretion in the urine decreases. So that's how you conserve free water. That's the mechanism. And clearly, if you have too much AVP, then there's a lot of more aquaporin water channels being opened up, then more free water goes in, and that's why SIADH occurs. So for patients with functional adenomas, like acromegaly, growth hormone is helpful after at post-op day 1, because if you have a nice drop in growth hormone, you know that you've taken most of the tumor, if not all of the tumor out. IGF-1 is not a helpful marker after day 1 or day 2 because it takes a much longer time to drop. Prolactinomas, if you're dealing with a prolactinoma post-surgically, again, if you have a prolactin level that has dropped, that's also very helpful because prolactin levels, if they do drop and it doesn't hang around in the circulation for very long, if it drops, then it's a good sign that you've taken most of the tumor out. Cushing's, as Zach says, is a bane of his life. It is for me too, and this is where patients need to be monitored closely because you want to ascertain if they are in remission or if they're still hypercortisolemic. So again, if you go to different institutions, they'll, different places do it differently. We basically put a line in and we measure their cortisol levels every 6 hours after their surgery. And the aim is to hopefully see a downward trend of the cortisol levels that drop below 5. Hopefully, if it achieves a level of 5, then we switch and increase the frequency of serum cortisol levels measurements to every 3 hours. The idea is to see where the cortisol nadir is, because that will give us an idea of whether the patient is in remission or not. And if the patient's not in remission, then clearly we don't need to give them steroids. But if they are, then they need to be started on hydrocortisone. Typically, we use 2 as the cut off to start them on steroids. I would think it's probably about 3 to 4 hours, which is why we tend to use 6 hourly. Yeah. So this is a nice paper from NIH, Leonard Niemann's group, looking at the nadir cortisol, and that's where they kind of accepted the value or the cut point of 2 to predict the long-term remission of surgery. Now, if the patient still has cortisol levels between 2 and 5, again, from this study, it is possible that they are cured, but certainly these patients need to be followed up and cortisol levels need to be measured later down the line, which is why they need long-term follow-up. So there are 3 possible scenarios with Cushing's after surgery. Clearly, what we hope to achieve is the remission, where you've nicely taken out, you chewed out the tumor, kind of like the Apple logo here, and cortisol and ACTH levels drop, and the patient really doesn't need any steroids, or will need some steroids to go home with, but in the long term, they don't need any steroid replacement. But unfortunately, in a less than ideal world, we have these 2 potential scenarios. One is if the tumor is still, or there's some tumor cells left inside, then the patient still remains hypercortisolemic, and that's when we'll have to think of other strategies in terms of treating this patient. Alternatively, you can have a patient where you've taken it, or you think you've taken all of the tumor out. The biochemistry is heading the right direction, and then within a few days or within a few weeks, it bounces back up. And clearly, what happens is because you kind of stunted the ACTH producing cells, and then over time they start producing again, and that's when you have a recurrence of Cushing's, and that's when you have to again figure out what the next step is for this patient, whether surgery is an option, or repeat surgery, or medical therapy, or radiation. We tend to see them 6 to 8 weeks after surgery, 8 weeks for those with Cushing's. These are the labs that we measure in these patients to assess their overall pituitary function. And then perhaps after 12 to 24 weeks, we see them again. And this is around the time when we perform the MRIs. And I do know that some surgeons prefer to do it at around 12 weeks, and some surgeons prefer to do it 24 weeks for the MRIs. And you guys decide. But it's around this timeline that we repeat the MRI to see what's left behind in the pituitary. And obviously, they need long-term clinical, biochemical, and imaging assessments. So this is the American Association of Clinical Endocrinology recommendations for perioperative management of pituitary tumors. This is the algorithm that that's put out by Whitney Woodmansee, which I believe you've worked with in Brigham's. So we tend to follow this algorithm here, except for the fact that unlike, oops, I go back. Yeah. So instead of measuring their cortisol levels at week 1, we generally measure just their sodium levels at week 1 and week 2. And this is where we hand them this surgery packets with, and we give them lab slips in here for them to take home. At post-op day 1, we spend a few minutes talking to the patient. So we tell the patient, go home, have a lab draw at week 1 and week 2 to measure your sodium levels. We also give them a little bit of a reading material to help them understand what surgery is and what to look out for in terms of potential complications. So they go off and have their labs drawn, usually at any lab of their convenience, and our nurse will basically track down these levels, and we have to take a look at them and see what the results are, week 1 and week 2 of these for the sodium levels. But otherwise, pretty much how we manage these patients is very similar to the algorithm that's proposed by ACE. And so we're on to the cases now, and I thought I'd highlight some cases to highlight several points. So this is a 42-year-old female, 16-month history of amenorrhea, decided to stop her pill after 20 years, and suddenly she finds that she's amenorrheic. A little bit of galactorrhea, mood swings, and low libido, and hormonal evaluation when she saw us was pretty much unremarkable, except for low gonadotrophins and a pretty modest elevation of prolactin. She has a macro, her visual field is normal, and because of that, I thought, well, maybe trying her on cabergoline would be appropriate, at least to see if she responds or not. Fortunately, she didn't tolerate it very well, and 3 months MRI didn't show any degree of tumor shrinkage. So surgery was recommended. This is the MRI. As you can see, it's pushing up the chiasm a little bit there. Surgery was uneventful. She developed signs of diabetes insipidus after post-op day 1. Sodium was of 145 with appropriate low urine specific gravity. So we gave her, again, remember, we treat her as needed with oral DDAPP, and she responded very well within the next 3 or 4 hours. Following day, this should be post-op day 2, sodium levels were much better at 141, and she was discharged with no medications. On day 6, unwell, headaches, nausea, and it was around the time that we gave her these lab slips. So she took these lab slips, had her labs drawn, and her sodium had now dropped to 131, osmolality of 274. So we advised her over the phone. We had a nurse who tracks these results, and she calls her up and tells her maybe, most likely she's having SIDH. Restrict your fluids, take liberal salt diet, and recheck your sodium levels the next day. Headaches were worse. She didn't even make it. So we decided to bring her in, and you can see that the sodium levels when she came in on day 8 was 129. So we decided the following day, as the sodium levels continued to drop, to give her a hypertonic saline infusion. And it wasn't until day 10 the headache started to improve, and day 12 that we stopped her hypertonic infusion when her sodium levels were gradually getting better. So it takes a while, and we didn't really put her on tolvaptan. Maybe we should, but this is perhaps a cheaper way of managing her from drug standpoint, although she was hospitalized for a much longer period than she would have liked to. So I was preparing this actually for one of my conferences, so I'm just going to put this out. So factors that increase the risk of persistent post-op DI. Does anyone? So is it A, repeat surgery? Yes, no?
I'm gonna call on Bill here. Bill, what do you think?
I'm going to say not necessarily.
Okay. Intraoperative CSF leak.
No, I think maybe D, perioperative.
Okay.
My thought, more likely postop.
Okay. More than one right answers, by the way.
Oh, okay. And maybe A as well.
Okay. What about B?
B, I don't think so. I mean,
Okay.
if you end up tearing the diaphragma,
It's okay.
you get the CSF.
Yeah.
It's not
Okay.
really
What about Rathke's?
I haven't seen many Rockies, so I'm not sure on that. I mean, anatomically, maybe yeah, it's stop.
Okay.
So we need to work on your test taking strategies. He said more than one thing can be right, and he's smirking at you. So all of the above might be a good answer.
Could be. Acromegaly, typically large tumors. Well, actually, this is a study that they looked at, and generally acromegalies tend to do quite well in terms of post-op DI, even though most of these tumors are large. And pre-op hyponatremia, again, is not a factor that increases the predisposition to post-op DI, okay? But yeah, so repeat surgery, CSF leak can sometimes do it. Cranios and Rathke's cyst is, I presume, is because of the location, I think, of the cyst. And we had that woman recently that had persistent DI that, her location of that cyst was actually right, was it just
In
above?
the stalk.
In the stalk, yeah. So, yeah. 35-year-old acromegalic, large tumor, no question about the pre-op diagnosis, does well post-operatively. So she comes back to see us and we do her labs. IGF-1 was still raised and she's otherwise no headaches or joint pain. She's otherwise still concerned based on that, whether she has persistent acromegaly or not. So this is the tumor and one right answer. What do you do next?
Dr. Patel.
Usually I do this in the meet the professor sessions, and it's quite funny because you get a wide range of people. You have those clickers of,
Right.
and then
Audience polling.
audience polling. What do you think?
I want to say E, start therapy.
So you're saying this person still has acromegaly, the surgeon has not done her any favors, and you just
Now,
go on
I
medical
want to
therapy.
point out answer A. So when you're presenting to a group of endocrinologists, that's okay. When you're presenting to the neurosurgeons, A should be obtain another IGF-1 level and refer back to endocrinology.
You mean A? Oh, okay. Okay, fair enough. Yeah, it's kind of audience dependent, but certainly the point I'm trying to highlight is, idea is perform an OGTT because IGF-1 is not a reliable marker because it takes a while to drop after surgery, okay? And this is some data to show that. So IGF-1 normalization can be up to as much as 10 months after surgery. So don't base your diagnosis or the status of the patient on just purely on IGF-1 alone. And this is some studies looking at patients with acromegaly. And you can see that even as far out, so this group is for those who are delayed cure meaning after 3 months. So the breakdown of delayed cure group, you can see as far out as 48 months, 60 months, 7% of patients still had, took them 60 months actually for them to normalize. So IGF-1 may or may not necessarily be helpful in this situation. So that can actually fool you.
How do you explain that?
Because it's a long half-life, and also it's dependent on the liver in terms, because the IGF-1, 95% of IGF-1 is secreted from the liver. So sometimes you can have many other factors that can contribute to affect the IGF-1 generation from the liver, which is why we typically prefer sometimes using the growth hormone, which is a little bit more accurate. Okay. Cushing's 36-year-old female, post-op day 2 after surgery was 3.4. Pathology confirmed it, and she felt well. She was discharged, and 3 days later, feeling unwell. Okay. So again, what's the next step? Again, audience participation required.
Dr. Bentley.
Cool. Yeah. So the reason is, once you've taken out the tumor, the ACTH producing tumor, the surrounding tissues or the surrounding pituitary may or may not actually start to respond to produce ACTH. So they could end up dropping to having AI before they start normalizing. So if in doubt, obtain a serum cortisol level and start them on hydrocortisone. Good. And these are some data showing the dark line, all the patients that were followed up to post-op day 3, who later on were deemed to have surgically cured, as opposed to those who were failed. And you can see here, even at post-op day 1, the cortisol levels around 6 or 7 were being cured, and post-op day 2, again around 6 or 7 as well. So don't be too anxious if you find that their cortisol levels are a little bit high, because they can end up being cured as well. For those who failed surgery, you can see if your cortisol levels at day 1 is around about 10, then you know that they're most likely that they're not cured, actually, based on this study anyway. We don't typically like to give them steroids for surgery, and I know, like I said earlier, some places do. And the reason is there's some suggestion that they actually do prolong their hospitalization. So typically, if we find, so this is a study by actually in Stanford, where they looked at retrospectively patients after surgery, and they measured their cortisol levels post-op, and if their cortisol levels were less than 5 in the morning, they would put them on hydrocortisone. But if they are in between 5 to 12 with symptoms, they would still put them on hydrocortisone. Whereas everybody else, they didn't put them on hydrocortisone. So point is, we generally don't like to put them on hydrocortisone if we can avoid it, because of the fact that it increases their hospitalization. So when in doubt, for steroid, consider giving that, but make sure you check their cortisol levels before giving them glucocorticoids. And be cautious labeling a patient as having adrenal insufficiency without biochemical confirmation. And always consider retesting these patients at a later date. It's easy to retest them even if they're on hydrocortisone. Basically what you do is you tell them to hold off their hydrocortisone during the day of testing, and that should be fine. These are the hydrocortisone doses that we tend to give patients, maintenance doses. I mean, these are just guidelines again. If there are major illnesses or they have procedures, if they're able to swallow, or preferably oral doses. If not, IV doses would be okay. We know that for surgeries involving the pituitary, a multidisciplinary team approach is required. make sure that the hormonal status is assessed prior to surgery, because it's important to minimize the comorbidities in these patients, and they typically tend to be, they need to be followed up for long term. Thank you.